This is an age of disruption, of profound revolutionary change.
What we're really asking ministers is to empower the ambassadors.
The only thing that you really push forth is the truth.
You don't see many women represented when it comes to the decisions as to how to handle the pandemic.
Good afternoon. I'm Carlo Martuscelli, a health policy reporter with Politico. I'm coming to you from Hotel NH Berlaymont in Brussels and welcoming you to our live event, Unlocking Access to Biosimilars in Europe, What's the Way Forward? The past few decades have seen a sea change in the pharmaceutical landscape, with the arrival of medicines like Humira, Avastin, and Herceptin. These treatments, which are called biologics, are different from common drugs like aspirin and antihistamine. Instead of being relatively simple compounds synthesized through a chemical process, biologics are complex organic molecules which are made from and extracted from other living organisms. There's another difference between these simple drugs that came before and biological drugs, and that's the price. They can cost tens of thousands of euros or more. But patent and market protection for biologic drugs, like for other kinds of medicines, only has a limited lifespan. When it runs out, rival drug makers can launch their own unbranded versions of the product, bringing down the price. These are called biosimilars. In 2004, the European Medicines Agency introduced a regulatory pathway to approve biosimilar medicines. These aren't the exact equivalent to generic medicines, however, both because of the difficulties around producing biologic-type drugs, as well as the process to validate them in order to make sure they really are medically equivalent to the original pharmaceutical that they're based on. The incoming pharmaceutical package, which is just about to be debated in the European Parliament, is going to change various different aspects of the unbranded drug market. For example, there's the modulation of incentives, there's transferable exclusivity vouchers, and the Commission has also rewritten the bowler exemption, although we'll have to see if that makes it through the whole legislative process. Today, we're going to be looking at the regulatory landscape for biosimilars to see how it's changing. We're going to be discussing all of that and more with our panelists. But first, a few housekeeping remarks. As you're aware, Politico does make every effort to maintain diversity and balance on the stage. That goes from gender, nationality, political perspectives, and we were meant to have MEP Susanna Solis-Peres here today, but due to a last-minute scheduling change, she couldn't make it. However, we're delighted to be joined by our expert speakers that I will soon introduce to the stage. And of course, I'd like to thank our partner Sandoz for making this event possible, as well as thank our Politico Live team who've made it all come together. We do like to make these events as interactive as possible, so you can participate by tweeting about it at Live Politico, and you can also ask questions on Slido using the hashtag #UnlockingBiosimilars. I only ask that if you do so, you give your name and the name of your organization in order to be as transparent as possible with our panelists. And you can already begin to share your thoughts and answer the poll presented by our partner Sandoz. The question is, which action would have the strongest impact on unlocking more biosimilars for Europe? We'll look at the results at the end of our panel. Now we're going to hear some opening remarks from our partner Isabel Remus, Head of Commercial Region Europe at Sandoz. She's going to join us through a video that we'll just show right now.
Welcome. Thank you for joining us today. My name is Isabel Remus, and I'm the head of commercial for Region Europe at Sandoz, a global leader in generics and biosimilar medicines. Sandoz recently separated from Novartis by way of a 100% spin-off, but our mission has remained unchanged: to pioneer access for patients. We were the first company to bring biosimilars to the world, starting in Europe back in 2006. We now have 9 biosimilars on the market, with more than 20 in our pipeline. We aim to increase access to advanced biologics by bringing high-quality, affordable, and potentially life-changing biosimilar options to market. Nearly 2 decades since their introduction, we've witnessed the impact biosimilars have made in Europe. Biosimilar market entry stimulates competition. It allows for broader and earlier treatment with biologic therapies, which can improve patient outcomes and supports healthcare system sustainability by unlocking cost savings to allow for additional services and reinvestment in innovative medicines. To quantify their impact, cumulative savings through biosimilar competition has now exceeded 30 billion euros in Europe alone. As I look to the future, particularly in this period of reformation for EU pharmaceutical legislation, I imagine how much greater the impact of biosimilars can be. According to a new IQVIA report on biosimilar void, in the next 10 years, exclusivities for over 110 biologics will expire in Europe. However, indicators suggest that less than half of those losing exclusivity in the next 5 years will have any kind of biosimilar competition. For various reasons, there are no biosimilar options on track to enter the market. Through my role as the chair of the Biosimilar Medicine Sector Group for Medicines for Europe, it is clear to me that there are policies and regulations that are slowing down or disincentivizing biosimilar development. And while we're making progress, the time is now for breakthrough change. We must collaborate across the public and private sector to identify and address pain points throughout the biosimilar life cycle, from development to market entry and sustained presence. At all times, this is why I look forward to the discussion today. It is important that policymakers recognize the unique value of biosimilar medicines, the risk the producers take, and the difference with a generics business model. Biosimilar companies have many years of experience and data that can help inform how we get these medicines into the hands of patients faster. We're eager to collaborate on solutions to implement streamlined yet robust development pathways. I also want to recognize initiatives like Act for Biosimilars, which aim to facilitate greater approvability, accessibility, acceptability, and affordability, the 4 A's of biosimilars. Today, in the coffee area, you will see copies of the deep dive report for Europe, which launched earlier this week. This report outlines specific European insights and challenges to biosimilar adoption. The initiative is near to our hearts, and we believe it is part of the solution to unlock access to biosimilars in Europe. If we want more people to live longer and healthier lives, we need to make smarter use of biosimilar medicines today and prepare for the future. But a more favorable market environment for biosimilar adoption is key to encourage companies to keep investing in the development of expensive and complex biosimilar programs and ensure that novel biological treatments remain accessible to patients. There's much to be gained across stakeholders. It can be a win-win for all. We look forward to collaborating to support better outcomes for patients and greater sustainability for healthcare systems with biosimilars. Conversations like the one we're about to have now are crucial to improve patient access to medicines and to support more sustainable healthcare systems, not just in Europe, but globally as well. Today, we are focusing on Europe a couple of weeks before we engage in a similar discussion with Washington Post and another event with BP Nikkei in Japan, which is planned for next month. We want to take an active role in bringing the right stakeholders together to optimize policy and to develop robust long-term solutions for unlocking the promising potential of biosimilar across the globe. Thank you, and I look forward to hearing the discussion between the panelists in the next hour.
Okay, great. Well, if maybe our guests can join us on stage, and that really interesting discussion will help inform what we're about to speak to. I mean, one thing that struck me was that amazing statistic that apparently half of biologic drugs that are expiring don't have a biosimilar being prepared, that Isabel said right now. But before we get to that, let me introduce our guests who joined us on stage. We have Adrian van den Hoven, Director General of Medicines for Europe. And we have Max Newton, Engagement Manager at IQVIA. Thanks so much, Adrian and Max, for joining us today to talk about biosimilars. Adrian, I thought we could start the discussion off with you, which is just this word biosimilar. I know when I first encountered it, it sounded very technical and a little scary. I tried to give a simple explanation of what they were right at the top there, but you know, what exactly are we talking about when we speak about biosimilars, and why do people use them? I mean, what's the advantage of biosimilars versus other types of medicines?
Well, thanks, Carla. I think you did a pretty good job of explaining it, actually. So biosimilar medicines, the actual technical term is similar biological medicine, actually, but it was shortened to biosimilar medicines in kind of the common language. So biosimilar medicines are a follow-on version of a biologic originator medicine, and they have to follow a special regulatory pathway to demonstrate that they're highly similar in medical effect, as you pointed out, to their reference products, so that basically they work the same way for the patients that take them. So these are relatively new because, as was pointed out, they were only introduced into the legislation in 2004, and the first biosimilar was available in 2006. But now they're available for a wide range of very important therapy areas, from cancer, ophthalmology, diabetes, fertility, immune conditions. And the big challenge, I would say, in this space is these are specialty areas, what we call in pharmaceutical specialty areas. And of course, there's a lot of cost in the biologics space. So they bring competition, and therefore they can lower the price of the medicines for the health insurance. But more importantly, they can increase the access. So far, biosimilars have increased access by 50%.
Just to really simplify that, break that down. So more competition means lower price, which means more medicine for patients, essentially, or more patients being able to get that medicine. Is that a...
Exactly. So I'll explain a little bit in detail. So in almost every country, when you have an expensive medicine, okay, there is some form of restriction on that medicine. Of course, no governments want to acknowledge this, but in reality, the doctor may have to fill in a bunch of forms, may have to get a special authorization or something like this to prescribe the expensive medicine. When you have then the price competition and the prices go down, then typically, unfortunately not everywhere, those restrictions will be lifted, and then there's a possibility to treat more patients, or maybe even the guidelines can be changed.
Okay. So, and do we usually see this borne out in real life, that generally when a biosimilar is introduced, we see more patients receive the medicine, or? So
we definitely do see it because there's been a 50% increase across the board. Unfortunately, what I would say is that we see it more in the West European countries who already have better access to the, let's say, the original versions.
Right.
And less in the Central and Eastern European countries, but it's starting slowly to change. So we're starting to see now some unlocking of the access in the Central and Eastern European countries as well. But for, let's say, a short period, and I think IQV has noticed that as well, it hasn't been as strong growth as we would have expected.
Okay, great. I'd love to dive into some of the reasons for that disparity between East and West, something that unfortunately we see repeated in the pharmaceutical market across many different areas. But before we do that, Adrian, you set us up well for my next question to Max, which is, we were talking a bit about use and how popular these are. Max, can you give us some figures? Can you give us a sense of how important these medicines are, just to show people who are listening and viewing that this isn't a niche thing, this is a big market, both the market for the original biologics and also for the biosimilar competition.
Absolutely, and I think this is why I have my cheat sheet, because I'm bringing in a lot of stats from this. And I think the way to look at it is to say, firstly, you have to consider the role that biologics, not biosimilars, play in the total pharmaceutical landscape. So say in Europe, you have a market size of around 200 billion. At the moment, biologics themselves, so that's originator products plus biosimilars, any biologic molecule, is about a third of that.
A third?
Is about a third of that, and that includes the products that are protected, it includes those that have lost protection, and biosimilars. So as we kind of filter down, going from your total market to what's biologic, what you then have is you then have a smaller segment of the market that's true biosimilar spend. And from a spend perspective, that market size is around 9 billion at the moment, but let's take the most important point into account, which is, yes, that's a relatively small figure versus the 35% of 200 billion. But the benefit of that is that those products are bringing down the cost of the other originator products, and additionally, they bring significant savings at list price levels. We also need to take into account the fact that some of these products can have discounts of up to 80%, maybe even more in some cases. So what we see is, one, they play a significant role in the market. The second is, and I think Adrian and Isabel briefly touched on it, is the numbers. So as in absolute figures, how many products are we talking about? Yes, there's lots of therapy areas, and yes, the European market has evolved significantly since 2006, when the first biosimilar was approved. We now have 20 therapy areas, or 20 molecules, sorry, where we have a biosimilar available. We have 80 biosimilars in total. Simple maths tells you, well, that's 4-1, but that's also not necessarily true. You actually have some molecules where you have higher amounts of competition and some lower. So we've got their importance of the role in the market, their general scale in terms of numbers, the savings. I think Adrian's briefly touched on that, and I think it's really important to highlight biosimilars, their true impact versus what we'd previously predicted. So if you go back in time and you look at what had historically been predicted for the potential savings from biosimilars, their impact was expected to be somewhere in the region of 12 billion up to kind of 35. You heard just a moment ago that figure as of now is around 30 billion at list prices. So they're delivering significant savings across the European healthcare sector. And then obviously taking into account those three pieces, the importance of the biosimilar market, to not just payers making savings, patients receiving treatment, but also to the general healthcare system sustainability is super vital.
Mm-hmm, mm-hmm. And I do want to get into the question of why we're not seeing a biosimilar for every product. I think that's quite curious, and Adrian, maybe you can correct me if I'm wrong here, that's a difference between biosimilars and generics, where we would generally expect there to be a generic product. But before I did that, can you just give us a sense of what these drugs do? I mean, what are the, I realize there's many different treatment areas, but where do we see specialization and where these, complex molecules might be able to do certain things that the simple small molecules can? Sorry, that's a bit of a complicated question. To rephrase, which diseases are they most commonly used for when we're talking about biologics, or can we not generalize?
I think we can say, there's a big segment of biologic usage in immunology and in oncology where you're looking to basically have a more complex molecule that can be targeted to a certain cell type or be targeted to a certain tumor type, for example. And so those are the areas where you see the most breadth of biologics, but they're also, I think the counterpoint to that is they're also the largest therapy areas generally. They're areas that have the most patient kind of need. They're also significantly higher volumes of patients than for, let's say, a more niche use of a biologic, which would be in, say, ophthalmology, for example.
Mm-hmm. And how are we seeing this evolve? Are we are we expecting this to only pick up pace from here in terms, not of the biosimilars, but just this biologic trend that we've seen?
I think you could say, if you look at pipelines, biologics are still a big segment of the future pipeline, around 50, 60%, I'm not sure the most recent numbers. But what you also have beyond that is you have that next level of innovation, things like antibody drug conjugates, like cell and gene therapies. So we're kind of in a period where we're moving from small molecules targeting certain things to complex biologic molecules to really complex, single patient, incredible technology.
Great. I wanted to ask you, Adrian, this is my impression, and correct me if I'm wrong, maybe one of the difficulties of making and developing these biosimilars is the fact that actually the way the standard they're held to, or the way you validate them to make sure they really are the same compared with the original product, is quite a bit more stringent. And that makes sense, I guess, because the way they're made is, I don't want to say more of an art than a science, that's not true, but because you're using biology to produce them, there's an inherent variability to it, I guess, which shouldn't impact the treatment, but at the structural level, there's a slight bit of variability, and you have to make sure that doesn't affect the treatment. So what would you say about the standards or the way that biosimilars are validated compared with generic drugs? What does that process look like?
So I think really biologic drugs have been around for about 30 years, right? So what you have to also keep in mind is that the technology to develop them, to manufacture them, has also evolved tremendously. Like the electron microscope, okay, you can see now 100 million times better than 30 years ago, okay? So it gives you an indication of kind of the leap in technology. So I think the technology is there for biosimilar development for sure. For almost every type of biologic drug, even very complex ones like ATMPs. I think the challenge is there a market for a competitive product? So can you have the biosimilar compete against the originator or not? In a very narrow niche market, it can be very difficult to break into. The second key question is sometimes some of the 50% that were mentioned earlier that are targeted, they are big drugs, actually. But there you can have other problems. So for the regulatory process, you basically have to do what's called a comparability exercise, which is based on comparing the molecules, that they have the same structure, that they operate the same way, et cetera. And then you have a clinical component where you compare them in a clinical trial, okay? The original and the biosimilar. And I think what
that part is different compared to generic drugs, is that correct?
Yeah, so most generic drugs, you wouldn't have that clinical part. For very complex ones, sometimes you do, actually, but for most, though, you wouldn't. But I think what's important for biosimilars is that for most biosimilar developments, the clinical part has not added to the science. meaning it hasn't demonstrated anything that the comparability part had not demonstrated already. And as you know, in science, you don't do clinical trials not to demonstrate anything, not to prove anything. And so the discussion is, okay, can we make this evolve away from this clinical part? And this is not just a cost, because for some biosimilar developments, the original drug was done in niche areas with very few patients, so you cannot find the patients, okay? So this can be a very challenging point also from a very practical point of view.
So if I'm understanding you correctly, you're saying that if we eliminated some or all, you can tell me, but of these clinical trials for the biosimilars, that would mean that it would make it easier to launch in some of these molecules that at the moment don't have competition.
Make it easier to develop. Yeah, make it easier to develop. Of course, there could be circumstances where the regulators would say, well, and that's also the case for some generics. They say, well, in this case, it's not good enough. You're going to have to do a clinical trial. But I think that should be the approach, that in the case where it's really necessary.
Okay. Well, let's talk about access now a minute, because both from the perspective of that pipeline of drugs that don't have biosimilars being developed, but also that geographic divide that we discussed at the start between East and West. So, and this is an open question, whoever wants to respond can respond, but why is it that some geographies have a much deeper penetration of biosimilars, and why do some not?
I think one of the first points you have to understand for a biosimilar is your purpose as a biosimilar, to some extent, is to generate savings from what was originally the originator being used to the biosimilar. Now, naturally, that becomes super challenging if you either had very low usage of that originator product or didn't have it at all. I think the first point to say is, let's take the example of where you have low usage to begin with. So you have relatively few patients treated, you have quite restrictive guidelines, for example, and ultimately what that means is, once a biosimilar is available, there's not significant savings to be made, and that incentive to then swap is relatively limited. That really happens in Central and Eastern Europe, whereby using any significant additional budgetary spend is very difficult. You take the Nordics, or Nordics is a great example, where they have relatively high usage, very high usage to begin with, and then as a biosimilar comes in at significant discounts, they're able to provide it, make significant savings, and even provide access to even more patients. So that kind of circular loop continues. The second discussion is where there's no access. And there's no access to originators is a biosimilar problem. It's not that these are, when something is effectively providing a discount, it doesn't necessarily, and we've proven in many cases, that it does not mean that that biosimilar can enter the market just because there's a potential unmet need. Where a biologic or originator product has been for, let's say, 10, 12 years in the market, there's a level of market development, there's a level of understanding, awareness, how to treat a patient, when to put them on it, when to take them off it. That whole approach really matters. And if you don't have that, then you get this disparity, and that's a very East-West Europe thing.
So it's a kind of knowledge, that last point, if I'm understanding it correctly, there's a kind of knowledge gap, like maybe the physicians aren't fully aware of how to use the drug, or?
I would say it's a small part, but it's part of the broader discussion.
Okay.
There are multiple different things, but when it comes down to, physicians across the board will be aware of a big blockbuster biologic, but are they familiar with it? No, not to the same extent where the product never existed.
Right. Adrian, do you want to add something to that?
Yeah, maybe on that last point, our members have had some experience launching biosimilars that were not really marketed by the originator in some Central and Eastern European countries. And there were indeed difficulties there because they had to educate the physician like an originator would do. Okay, how do you use this? Especially if it's an IV form of drug, it's more complicated, obviously. And so that obviously was a challenge. But there were other challenges, which is that when the biosimilars enter the market, sometimes the originators will shift to different drugs, and there's some reasons, financial relationships out there with the physician
Wait, sorry, you said when the biosimilar enters the market, the originators shift drugs?
To a different drug in the same therapy area.
Right.
So, for example, in Central and Eastern Europe, when a drug called infliximab was launched, okay, it's used for certain immune conditions. There were also some JAK inhibitors, another kind of drug that was launched roughly at the same time. So the doctor shifted over to the new drug and said, well, we're not interested in learning about this biosimilar because it's more.
So they went from one branded product to the other, basically.
Exactly. So this kind of compounds the problem, and that can easily be solved because you have policies, to encourage the use of the best value drug for that therapy area. These are typical policies that encourage that. The other thing I think what we've seen in some countries is around a lot of these diseases, you don't get access to the biologic immediately when you get the disease. You may have to go, for instance, if you have some of these immune conditions like rheumatoid arthritis or something, you're going to have to go on steroids or methotrexate or some kind of drug like that. And then as the disease progresses, you can get access to a biologic drug.
But that's similar with a branded medicine, isn't it?
But what we've seen is in 2 countries at least, Denmark and the UK, they've changed those guidelines so that now the patients get access earlier, so they're not so long on those drugs in order to reduce the progression of the disease. Right. So, and that's obviously because they can afford to expand the number of patients. For the UK, okay, they increased the access numbers by 40,000 patients, okay, by changing this guideline. So it's not a small shift in the accessible patient population.
And that's patients' health that benefits, just to make it clear, it's not just about money, it's also if more people get the medicine, hopefully they'll be healthier, if the medicine's working correctly. I did want to discuss the pharmaceutical package because there's 2 aspects to it. The first one is that, and either of you can correct me if I'm wrong here, but it doesn't actually say a whole lot about biosimilars directly, but throughout various provisions in the package, and whether that's the modulated incentive system, the vouchers, or the rewritten Buller exception, there are things that will impact biosimilars. So, Adrian, maybe we can start with you. What do you see as the most impactful changes, with the asterisk that, this is a long legislative process and what we talk about now might not be the case in a year or 2. But from the Commission's proposal at least, what do you see as the biggest deal?
Yeah, well, I think there are a lot of different things in there. Obviously, around biologic medicines, you have a lot of patents. So some of the blockbuster biologics have around 200 patents, let's say more or less surrounding them in different ways. Of course, you have the main compound patent, which is the most important one. It has the one with the SPC. Then you have a bunch of other patents there. A lot of those patents are irrelevant for the development and the launch of the biosimilar. And nevertheless, somehow our members can be delayed by these irrelevant patents, okay? And I think the Commission proposal around the Buller will not eliminate this issue, but it will cut through a lot of... Can
you just very quickly for our viewers explain what the Buller exemption is, just to give them that context?
Yes, the Buller exemption is just that you can basically infringe a patent for the development of a medicine to bring it to the market on the first day of patent or SPC expiry of that medicine. That's the main purpose, is so that you arrive on the day the patent expires onto the market.
And would you say it matters more for biosimilars, given that it's a rather more involved R&D process and, development process, really? Or
I think the more patents you have around the product, the more important it is. It's probably okay. So for a lot of biologics, makes sense.
And Max, is there other elements that you draw to in the legislation?
I think there's a lot to unpack in the legislation. We're talking about things about the improving access through launching in multiple markets and the implication on RDP. There's also elements around shortages, the development of the critical medicines lists. There are things around the changes to orphan drug legislature. And I think you're right to say, yes, there's no direct word for word saying this is what something will happen for biosimilars, but there is significant indirect effect. But I think I'll take your question and spin it and say, what does it not cover? Things like the critical medicines list included within the Commission's package. Shortages aren't necessarily a thing for biosimilars, at least at this moment in time. It's much more, it's not necessarily a biosimilars issue.
Why is that? I mean, is it because less of them are made in China or in third countries, let's say, and the supply chains are shorter, or?
No, I don't think it has to do with that. I think it's simply around the case that for those molecules, you have relatively fewer competitors. You have a completely different dynamic in terms of things like how products move, substitution rules, number of competitors, value of the molecule or the potential market value versus, say, a generic space. So I think that's one of the kind of big
less
differences.
cutthroat pricing, if I'm reading between the lines correctly, or?
Not necessarily, but I think it's a different market in that respect.
Sure.
And there's a whole discussion around what truly is causing shortages and, you know, what products truly are on shortage that I think you could have a whole discussion about.
And we have.
So I think you take things and say, look, to some extent, the critical medicines list doesn't have a huge impact on biosimilars. Changes to orphan drug exclusivity perhaps doesn't have a huge element of focus. One of the things that then does is the approach to say that modulated access, if you launch in multiple markets, or if you launch across Europe, that would have a beneficial impact for biosimilars because, as we talked, if you have the originator, it's better for the biosimilar in the end. It makes life a little easier. And then there's the AMR, the antimicrobial resistance transferable voucher. I think this is perhaps one where you could argue is not necessarily a great effect for biosimilars in general. It's likely the case that this transferable voucher will be used. So essentially, just a quick summary. You purchase a company developing an antimicrobial would then receive a voucher that they can then sell for an additional plus 1 year of regulatory data protection. They can sell this within the first 4 years after marketing authorization. They can only sell it once. And most likely, the buyer of that would be a large biologic product, given most of the big molecules at the moment are biologics. That would then be a company that would likely get the greatest benefit from purchasing a voucher, therefore delaying competition by 1 year.
Adrian, I think you have pretty strong feelings about the voucher proposal, and correct me if I'm wrong, they're not positive. So do you want to elaborate on what you see the issues are as applied to biosimilars?
Yeah, so I think if this is adopted in the legislation and we see these vouchers, I agree with Max. I think the likelihood is that these vouchers would be bought by the biggest blockbusters, many of which are biologics, and this would really screw up the biosimilar development plans, okay? Because you have to plan these things ahead. You have to plan your slot when you're going to go for your regulatory approval. You have to do all these things several years in advance, and then boop, you get an extra year of exclusivity, and that throws everything off. Obviously delays you by 1 year, but also throws your whole program into chaos, I would say, development program. So we're very much against this, also because we believe you can do this much more cost effectively with a financial program to incentivize this through EU financing. It will be much cheaper to do it that way.
I think the S&D rapporteur on the regulation, it goes in that direction, although the political discussions are going to be complicated. What about, I mean, that same point, though, that you made about the not being able to really plan your market launch if at any point you might get that plus 1 year, doesn't that also apply to the market launch mechanism or the unmet medical need incentives that are also structured that you can get a kind somewhat unpredictably, maybe a little less, but it might be hard to know when they're going to get an extra year or 6 months of data protection?
I think for the unmet medical need and the HTA trial bonus, I think those ones would be granted very early, right, at the authorization of the originator drug. So I guess there you would know pretty well in advance. Of course, when it comes to the market exclusivity for launch in all EU countries, that could be a little bit more unpredictable. There are ways to make it more predictable, of course. So I think we would suggest making this flexible or modulated market exclusivity for that aspect.
I do want to take a question from the audience now. Unfortunately, they are anonymous, and I prefer to take questions from people with names and titles, but it's a pretty good question, so we'll close our eyes this time. And the question is, how can we make sure tenders aren't going to go too much in the direction of generics making the whole system fragile? So this is a bit the question about the issue that we have with generics. And I know that, Max, you said there's different schools of thought as to what is causing the shortages, but one issue people think is that the way we structure our tendering is a kind of winner-takes-all, concentrates risk, supply chain risk in just one vendor, because we're just looking at price, we're not looking at supply. So if I'm interpreting Anonymous's question correctly, is this an issue for biosimilars, do you think? I mean, as you said, so far we haven't seen this issue, so maybe actually shortages isn't something we need to worry about. But Max, I'll start with you, and then we can go to Adrian.
I think one of the things that is really going to be useful in the discussion around how a sensible tender system runs is the whole topic of what we've called the biosimilar void. So
biosimilar what?
The biosimilar void, instances where biologic products don't have a biosimilar in development. And what I think that does is it really highlights that if you treat this market the same way as you would with a small molecule generic market, what you will end up with is significant gaps, issues, loss of savings, and loss of patients treated. So I think for us, that's a really new, good example of saying why and how ultimately you should be considering that the current tender framework to be improved, optimized, or changed. It's a really good example to show significant numbers of biologics don't have competition. It's almost $15 billion of upcoming savings in the next 10 years. That's no pocket money. That's important savings.
Yeah, we'll go over to you, and then I had a follow-up question.
Yeah, go ahead.
Actually, but first you, Adrian.
Yeah, no, I think there is starting to be some understanding now that we need to move away from single winner, price-only tenders. There have been a couple of experiments for some biosimilar tenders to move away from that, to have basically to divide a country into regions and to have different regions. That way there are more suppliers also for the next tender. But I think as, these are really piecemeal exercises. So maybe we'll see. I mean, I think the Commission is going to introduce this guidance now on procurement. I think that will spark quite a big discussion as it moves forward. Most of the payers say they want to go in this direction, but we don't see that yet in the practice.
Sure. Max, I wanted to ask you a follow-up question on, I like how you framed it around this biosimilar void. And we mentioned that the pharma legislation doesn't directly address biosimilar, although, of course, various provisions do impact it. Is there any simple, obvious solution that we're missing here to get more biosimilars to the people who need them? Or is this one of those just kind of difficult, intractable health problems that go across from HTA to budgets to a million other different things?
I wouldn't say it's intractable, but I also wouldn't say that it's not solvable. There's certainly approaches that can be made to ultimately resolve it. But as always with anything in healthcare, you're so right. It's super complex. There's so many interwoven pieces. I think it's important to look at what types of products are impacted before we then discuss what the solutions are. So I think from our research, there's 6 or 7 big categories. There's oncology medicines, believe it or not. So we're talking about big oncology biologics, whereby the cost of procuring a comparator in the trial for a biosimilar could be millions of dollars, because it's originally a high-cost product. The discounts are in a commercial environment, so anybody purchasing it would usually pay the kind of full list price. You then have instances where there are products that are lower value, i.e. they don't necessarily make that much commercial sense, and there's a number of different reasons for that. It could be the case that standard of care has moved on. You don't necessarily always need a biosimilar for every biologic. That's an important nuance. Then you have things like combination therapies or second-generation therapies, as Adrian talked about, where we're seeing instances where you're unlikely to get a competitor. Then you get to the really tricky stuff. Then you get to cell and gene therapies or antibody-drug conjugates, and you get a whole discussion around whether they're really biologics or whether they're biologically made. It's a whole kettle of worms. But
and you have no regulatory guidelines to do a biosimilar to that kind of product either. So even if you wanted to,
it's
there's no actual process. But
it's looking so far ahead.
And is this for antibody-drug conjugates specifically, or
for ATMPs
for
or other
ATMPs,
things like this? You have no process for some of these very, very complex things. So even if you wanted to, you'd have to invent yourself as a manufacturer, let's say, the process, which is a very difficult thing to do with the regulatory authorities.
Yeah. And then from those categories, you can say, well, some of those categories have relatively clear approaches where you could say, I missed a really important one, the orphan medicines. So orphan biologics, at the moment, we see 3% of them have a product in pipeline, have a biosimilar in pipeline. And even if you look over the next 10 years, taking into account it takes 7, 8, 9 years to develop a biosimilar, there's still 3%. So that's a very small proportion. And these can be products that are relatively high value, like valuable enough commercially to pursue for a company. But at the same time, what you then have is the potential risk of no competition. So there's set challenges by group, and there's also set solutions. So one of the examples we've already briefly talked about is streamlining the regulations and the kind of comparability section of the clinical trials, where, generally speaking, it's more common knowledge that it's not used in real practice. You can also say there are instances where it would be beneficial to have a aligned regulatory process, sometimes even a regulatory process. It would be useful. It would be useful to have potentially for a product that doesn't get competition after 15, 20 years, a simple price cut, where you essentially say the molecule has not generated competition and it's been sitting here at its same more or less price level over time. That's what the Swedish model does. After 15 years of no competition, we then reduce the price as if there was a biosimilar.
Oh, that's interesting. Has that been applied?
Yes, Sweden's a good example. And it's a relatively recent change. And then you've got, I think, one of the kind of simple wins, going from our really complex, streamline the regulatory process, clinical trials process, through to discounting, is the simple one, which is horizon scanning. Just simply knowing what's coming up and what the status of development is. That's a really simple, quick win to say, where do we have gaps and perhaps what should we be doing about them? I think our recent study that was just published is one of the first that really shows this, and I think it's taken a lot of people by surprise.
I also wanted to situate Europe internationally, both in terms of the regulation, the regulatory pathway, and the market. Is Europe a particularly good market for biosimilars? Does it have more biosimilars than other geographies, or is it lagging behind? And how do the rules compare to the US or Japan, for example? Do we see any convergence? So that's an open question, whoever wants to jump in.
So Europe is definitely ahead in biosimilars. This was a technology invented here, a regulatory process invented here. And so we had a 10-year advantage over just about everybody else. So Europe was really the pioneer and still is ahead. So I think the US is catching up now. They have kind of a convoluted system, but they nevertheless eventually developed a very similar regulatory approach to the European Union when it comes to biosimilars. So now you see the market starting to develop there. But as you've lived in the US before, you know, they have this kind of crazy system where sometimes the higher list price drug has an advantage on the market to the lower list price drug, which the biosimilar would have. So it's sometimes difficult to get traction in the US market as a result of that kind of upside down system that they have in terms of the market. And there is quite some growth in emerging markets for demand for biosimilar medicines. I think the difficulty with emerging markets is you need highly specialized regulatory authorities that know the regulatory comparability exercise. This is the more difficult part. And that's still a work in progress where the WHO is trying to train or educate these regulatory authorities in those countries to be able to do that. Otherwise, they have to rely on the regulatory approvals, say, of the European Union.
Okay, so that's quite specialized and technical, obviously. Max, is there anything you want to add to that, or?
No, I think that's a neat summary. I mean, you can look across different areas of the world, but it really is a European thing and a European start. I think it's also, I guess, important to note that obviously the development of biosimilars in general is a global thing. You know, you develop a pipeline, you develop a product, it's a global product. Where you launch and the development of access, that's a country or a region-specific thing. But pipelines in general should be available everywhere.
Sure. I have another question from Slido. This is from Mikhail Kukushkin. And Mikhail asks, how would the upcoming HTA regulation impact biosimilar access pathways? So, first of all, will the HTA regulation impact biosimilars at all? Does it impact biosimilars? I mean, it's already been passed, so.
I don't think it will have a huge impact because the biosimilar comes in at a lower cost to the already HTA-approved drug, so it's just maybe changing things. What can change is you can adjust the threshold to allow a drug that previously wasn't allowed under HTA. This happened with a combination drug, for instance, in the UK, where a combination originator was first not allowed because it wasn't cost-effective enough.
Right.
And with biosimilars, then it was cost-effective. But for the biosimilar itself, usually the governments are just happy to get a lower cost.
Sure, yeah.
I don't know, Max, if you would.
Yeah, I would say the same. I mean, you take UK, biosimilars are not reviewed through an HTA process. So HTA regulation or the HTA process in Europe, which is what we're talking about, might not necessarily consider biosimilars the same way as they would the originator product.
Does NICE look at biosimilars, or how does it work? Sorry, that's a very specific question.
Don't worry, it's a good background from my time living in the UK. No, not necessarily. It doesn't go through the same single technology appraisal or multiple technology appraisal process that the originator product would. They do review guidelines, so NICE ultimately has an influence on the guidelines. And there are recent examples where they've changed guidelines because of biosimilar entry, moved products up, moved products down, but not the same kind of submit a dossier,
right,
meet a cost effectiveness threshold, get a recommendation type approach.
This might be the last question we have time for, we'll see, but this one just piqued my curiosity because I'm not sure what they mean, but it sounds intriguing. To what extent are countries following the advice of the EMA last autumn that all biosimilars are interchangeable with the reference and equivalent biosimilars? So maybe that's saying that when a third when there's the originator, the first biosimilar, and then there's a second biosimilar, they want to make sure that countries aren't overpaying for the first biosimilar that will arrive to the market. I have no idea. That's just an interpretation.
So no, that's not quite it. So
okay.
Basically, the EMA and the HMA, which is the collective National Medicines Agency, they issued a guidance that said that the biosimilar was interchangeable to its reference product, and the biosimilar and the other biosimilar to the biosimilar is also interchangeable. So what that means, what this is really important is because doctors are the ones who would decide if you have a chronic condition, for example, and you're on an originator biologic, and then the biosimilar is available, the doctor would say, well, I'm going to switch your medicine from the original to the biosimilar. And this guidance provides legal certainty that this is allowed and from a scientific point of view. And in many Western European countries, this didn't have a big impact because this was already the case. Right. However, in Central and Eastern European countries, it did have an impact. So I know, for example, that in Romania, biosimilar is available in the community pharmacy, so not coming through the hospital, if you wish. There was not a lot of prescribing of biosimilars, but as a result of this interchangeability guidance, Romania changed its policy, and there is much greater uptake or use of biosimilars as a result of this. I don't have other examples yet of this, but I know for sure that this had an impact in that particular setting, and I imagine it's having an impact in other settings like that where biosimilar competition was rather limited.
I think it's interesting that we can talk about whether it's had an impact yet or not, and there's only a couple of known examples. I think in the next couple of months, as people start to look into it in more detail, they'll get a bit more of the answer. I think the anticipation, as Adrian says, was this is kind of this was already a known fact. This is what people did across the board, and to be able to measure that across multiple different Central and Eastern European markets in the next year as the kind of trickle-through approach happens will be really interesting.
Wow. So I guess it just goes to show how much of this is, I don't want to say awareness raising, but in a sense it is, to make sure everyone's on the same page as to when you can substitute a biosimilar, and making sure that pharmacists and the doctors know how it all works legally as well. So we've reached the end of our time, but before we wrap up, I do want to just quickly go through the results of the poll. To repeat, the question is, which actions would have the biggest impact on unlocking more access to biosimilars for patients in Europe? And at 53%, sustainable pricing and smart tenders with diversified criteria won. Next up under that was increased education on biosimilar value in partnership with governments and health authorities. And then it was simplification of regulatory pathways. And quite surprising, actually, really low is shorter exclusivity periods. That's only 16%. And then increased European production was at the bottom at 8%. So thanks so much for joining me today, Adrian and Max. That was a really interesting discussion. Yes, biosimilars are, it's a little bit technical, but actually it's quite understandable and of huge impact to health systems, sustainabilities, and access as well. So I think it's really important that policymakers and parliamentarians and everyone else in the Brussels health bubble really understands biosimilars. So thanks so much to you, and thanks a lot to Sandoz as well, and thank you to the audience as well for joining us, whether you came in person or online. We'd love to hear your feedback, so feel free to email us at live@politico.eu, and you can check out our events website to see what's coming up. We always have a lot of health events, so I'm sure you'll find something you're interested in. Thank you.
This is an age of disruption, of profound revolutionary change.
What we're really asking ministers is to empower the ambassadors.
The only thing that you really push forth is the truth.
You don't see many women represented when it comes to the decisions as to how to handle the pandemic.